All right, everyone, we're going to go ahead and get started. Welcome to the Neonatal Opioid Withdrawal Syndrome, or NOWS, Toolkit. My name is Caroline Tony Noland. I'm a program manager with the California Perinatal Quality Care Collaborative, CPQCC, and we are absolutely thrilled to have you here today. So this is a brief agenda that we have. We'll go over the different sections of the toolkit and provide you with a framework. We do have time for Q&A at the end. So if you have questions along the way, please go ahead and drop those into the Q&A box, and we'll answer them during that time. This toolkit is something that we've been working on for over a year. We're really excited to share it with you. It arose from a desire really from the maternal substance exposure, or MADEX, database. So this is a group of hospitals. It's a free database that are all voluntarily entering in information with CPQCC on infants who have been exposed to various substances in utero. It's primarily aimed at infants who have been exposed to opioids, but it's not limited to that. If you're interested in joining, please drop your email into the Q&A and I'll send you a follow-up email. But this is just a snapshot of some of the reports that you get as a member of the MADEX database. So you can see we collect information on toxicology screens and different types of non-pharmaceutical support, among others. This is a great way to really dig in deep in terms of measuring how you are providing care for these infants, how you'd like to provide care, different improvements based on interventions that you might be doing at your unit. So would really encourage you to join this database if you haven't already. And it's the folks participating in this database really said, hey, we would love a toolkit on now so that we can really get a better framework for caring for these infants. So here it is. So here's the QR code to get to the toolkit if you want to follow along during the webinar today. Kristen's going to drop the link in the chat. If you're on the CPQCC website, you can go to improvement tools, and it should be the very first one listed there. We want this to be a really straightforward clinical reference for you as you manage infants with NOWS. And while we did base this off of something that would be useful for CPQCC hospitals that are participating in MADEX, we really think the majority of recommendations are applicable to any birthing hospital. We do want to do a quick disclaimer while you're downloading the toolkit. We've tried really hard to be inclusive with our language in the toolkit. Where we use words like maternal or breastfeeding, those are in reference to specific actions or specific medical terms as defined by others. The authors believe that every family deserves to have quality, equitable, compassionate medical care. Here's an overview of the toolkit section. So we'll start by looking at preparation. Before an infant arrives in your unit, what can you do as an institution? What can you do with your staff to make sure that this is the best environment for them? We'll look at diagnosis, monitoring, and management while they're in the unit. And then how do we prepare them for discharge? The last section is additional resources, which will really point you forwards as you work with your unit to make a clear path that's specific to the needs of your patient population and to the experience level of your staff. And with that, I'm going to pass it over to Kristen.
Thanks, Caroline. So my name is Kristen Schaefer, and I'm a program manager. I work with Dr. Henry Lee at UC San Diego, but also support at CPQCC. So I'm just going to go over the first sections of our toolkit. As Caroline mentioned, they include both institutional and staff preparation. So we included these because we recognize that high quality care begins well before an infant is admitted into your unit. And so in these sections, we'll just talk about ways that institutions can equip their staff and lay a foundation for high quality, compassionate care. Before we get into kind of an overview of the content in these sections, we wanted to do a quick poll. And Caroline, I'm going to drop that for you. And yeah, if you could just share with us, we'd like to kind of see where everybody's coming from.
I'll give you about 10 more seconds.
Is it the final, Carolyn?
Yes.
Okay, sweet. So it looks like most of you have not received formal education or training on NOWS or opioid use disorder, which is kind of what we had thought for a lot of people. And so one thing that we wanted to include was some topics that are great to go over to include with training for your staff. All right. So first we have institutional preparation. So in this section, we highlight 4 areas that institutions can take actionable steps, as well as set goals for continuous improvement. So first, we discuss how institutions can commit to a culture of family-centered care. Many of you who may have been to previous webinars with CPQCC, this isn't a new concept, but this just involves partnership with parents and caregivers, support from leadership, as well as communication across the departments. We also discussed the importance of consistency in care, which the latest research and best practices all discuss this. This is achieved through standardized protocols, and those have been shown to decrease infant length of stay. Additionally, we discussed the importance of different departments collaborating and reaching consensus, particularly in their messaging to patients and families. One example of this would be how it relates to breastfeeding and neonatal opioid withdrawal syndrome and opioid use disorder. Another key factor is utilizing data to drive quality improvement. As Caroline mentioned, and many of you may already be aware of or participate, we have our maternal substance exposure database, which was developed in 2019. And so collecting data on all maternal substance exposures can allow you to identify areas for improvement, monitor the effects of interventions, and many other benefits to your unit. Finally, we discuss and recognize the need to develop and maintain written resources and materials that you can give to the families. We encourage you to regularly update these lists so that they are current on the resources that are local to your unit. And we also recognize that it may be helpful to develop relationships with some of the local organizations, which can make referrals easier for you. Within each section, we have references linked throughout, as Caroline mentioned. And unfortunately, we don't have time to go through all of them, but we did just want to highlight a few within each section. So within institutional preparation, we do link the MATX page that's on our CPQCC webinar or website. And this includes tutorials, manuals, as well as previous webinar recordings. So you can learn about participating and how it can benefit your unit. We also include a family-centered care tip sheet, which was previously developed by CPQCC. We have many examples from institutions, which are really great to see how other units, provide information and how they do things in their unit. So this is an example of a mother-baby bonding program booklet that UCSD has allowed us to share. And finally, we have an American Academy of Pediatrics handout, which discusses partnering with mothers. This is just one example of the many handouts and tip sheets that the AAP has developed. They're all really helpful. We've included many of them throughout the toolkit. And then we have staff preparation, which really highlights 5 relevant training topics that we think are good to include in ongoing staff training and professional development. Opioid use disorder, which we wanted to mention the importance in particular of having your staff understand the, what goes on in the brain changes, chemical changes that occur in addiction. This is particularly important as the rates of opioid use increase, as well as overdose rates increase. And then we have breastfeeding. we highlight topics specific to breastfeeding as it relates to NOWS and opioid use disorder. This is a key part of non-pharmacologic care, which has been shown to reduce withdrawal symptoms. And we also include some updated guidance on breastfeeding as it relates to other conditions, such as HIV, hepatitis C, and hepatitis B. We will, of course, go into those in a little bit more detail in the management section. Then, of course, we include training on NOWS, also covered in more detail in the next few sections. But we would just want, in particular, staff to be aware of the signs and symptoms to look for, and also understand the importance of being informed on the latest research, especially as we continue to learn more and more about NOWS. The last two training topics that we include are critical for creating a safe, compassionate environment for families and caregivers affected by opioid use disorder and NOWS. This includes trauma-informed care, as well as stigma and bias, both of which are increasingly recognized as important in high-quality care. Staff must recognize their own bias before they can make changes and modify their language and truly promote trust, safety, and dignity from those they care for. In this section, we highlight first a free online substance use disorder course that we found. It does have continuing education credits available as well, which is great. We also have a handout on organizational level steps for trauma-informed care. This was developed by the Center for Healthcare Strategies. We also have a webinar previously put on by CPQCC on Eat, Sleep, Console. And I will mention that we will discuss Eat, Sleep, Console more in the next few sections as well. And then finally, we have another handout from the AAP on recovery-friendly pediatric care. I'm going to pass it over to JD, go over diagnosis and monitoring.
Thanks so much, Kristen. My name is Jadine Wong, and I'm a neonatal hospitalist attending at Stanford Children's Hospital. I'm also a member of CPQCC's MADEX leadership group. I'm going to take a little bit of time to talk about the diagnosis and monitoring of an infant with NOWS. Next slide. First, we'll look at the types of in utero exposures. With regard to opioids, there can be both short-acting and long-acting opioids. Short-acting can be immediate or sustained release, and some examples are fentanyl, heroin, hydrocodone, or morphine. Long-acting opioids are for maintenance, and most commonly methadone and buprenorphine are used. Polysubstance use is very common among pregnant people who also use opioids. And the problem with polysubstance use is that can complicate the diagnosis of NOWS in the infant. So it's important to be aware of polysubstance use. And these substances can include stimulants, cannabinoids, hallucinogens, sedatives, SSRIs, alcohol, and nicotine. Next slide. When looking at the identification of NOWS in an infant, it's important to consider both pregnant person screening and testing, as well as testing of the newborn. Next slide. For screening and identification of the pregnant person, the American College of Obstetrics and Gynecology recommends universal screening with a validated verbal screening tool. And this will then guide toxicology testing in the pregnant person. Rehabilitation programs will often include regular toxicology testing. And it's important to keep front of mind to minimize stigma and bias and to be as objective as possible throughout the screening process. Next slide. For identification and screening of the newborn, a hospital protocol should also always take into account regional demographics and other factors that are specific to the hospital and to their population.
A toxicology test result for a pregnant person may be adequate for diagnosis of the newborn, but some outside agencies, such as CPS, may require actual testing of the newborn. A variety of testing modalities are available for newborn toxicology testing. And when looking at criteria for newborn testing, it's important to consider both pregnant person risk factors as well as newborn signs and symptoms. Now let's do a poll on toxicology testing. What toxicology testing does your hospital perform for newborns? So take a look at the options and make your best selection.
I'll give you about 5 more seconds, folks.
Right, so it looks like about half use a combination of testing, about a quarter urine, and then some meconium and umbilical cord. And then some people don't know. Often it's hard to know what your hospital protocol is or what testing is done. All right, next slide. So with regard to newborn toxicology testing, the different types of testing will vary by detection window, reporting time, accuracy, and cost. Most hospitals will use urine testing for the fast reporting time, and then combine that with meconium or umbilical cord testing, which has a longer detection window, but unfortunately takes longer to result. So it's important for each hospital to determine your testing protocol based on your regional factors, your demographics, and then also in conjunction with your laboratory, because every laboratory will have different parameters, will have different costs for tests, and it's important to check what actually is in a routine testing panel for your laboratory. Many synthetic opioids require more specific testing and are not going to be in a routine testing panel. As of January 2023, though, California state law now requires that fentanyl be included in all urine drug testing panels. Beware of false positives from common or prescribed medications when interpreting toxicology test results. Next slide. This table goes over some common factors in different modes of newborn testing. You'll see urine, meconium, and umbilical cord are there. Hair is used more for research purposes. It's not widely available. It can be quite costly. This table is included in the toolkit, so you can refer to that as much as you want. Next slide. So when looking at identification of NOWS in the infant, pregnant person risk factors should be taken into consideration. This is not an exhaustive list, but this list includes some of the common pregnant person risk factors that hospitals will consider when deciding when to test newborns for their toxicology. Inadequate prenatal care, history of drug use, especially illicit drug use in the pregnant person, signs of withdrawal or intoxication on admission of the pregnant person, history of incarceration or of child abuse. These are all areas where they may be considered risk factors and the infant should be tested. However, again, it's important to keep in mind using stigma and bias to guide in making decisions and being as objective as possible. Next slide. Newborn signs and symptoms will also play into when newborns get toxicology testing. Again, this is not an exhaustive list, but some of the more common signs and symptoms that we see in newborns who are withdrawing from opioids. And it's important to remember that all these symptoms can be seen in normal newborns. So it's a matter of what is outside the range of normal. I think we're all familiar with this high-pitched excessive crying that these newborns can have. They can be really difficult to console and have poor state control. They're often hypertonic and have tremors or can even have generalized seizures. Their sleep can be disturbed. They may have excessive sweating, sneezing, or yawning, again, out of the range of normal. They may also have poor feeding or loose or watery stools. Next slide. There are two main areas of assessment tools that are used when monitoring infants for NOWS. Traditionally, the Finnegan and its modifications have been most commonly used. These are standardized tools, and they're based on a variety of clinical signs and symptoms. By doing the assessment tool, you'll receive a numerical score, and that in turn will guide management as to a threshold to consider pharmacologic treatment. More recently, functional scoring is becoming in common use. And the infant's ability to meet basic functions is what guides management, because really our goal is to make these infants comfortable and able to function normally. As Kristen mentioned, this is most commonly known as Eat, Sleep, Console, or ESC. The infant should be able to eat at least an ounce or breastfeed well, should be able to sleep for at least an hour after feeds, and then be able to be consoled within 10 minutes or a reasonable amount of time. Next slide. With any assessment tool, it's important to consider comorbidities. It's important to think about what other etiologies could be causing the symptoms in these infants, and especially focusing on infection or neurologic disorders. And then with regard to how long these infants should be monitored with an assessment tool, for infants exposed to immediate release opioids, the recommendation is to monitor for at least 3 days. If exposed to sustained release opioids or buprenorphine, the recommendation is 4 to 7 days. And for methadone, a minimum of 5 to 7 days. Next slide. Now we'll focus a little bit on the management, some general concepts and recommendations. Next slide. Non-pharmacologic management is really the key in helping these newborns. It's important to initiate non-pharmacologic management at birth. And you really want to focus on prioritizing the caregiver-infant dyad. And ways you can do this are by rooming in, so the birthing person and the infant can be in the same room and in contact at all times. It's important to empower the birthing person and the caregivers to provide as much of the care for the infant as possible. And then when appropriate, to encourage and recommend breastfeeding. The hospital policy should include non-pharmacologic bundle of care factors, and these can be swaddling, kangaroo care, cuddlers, pacifiers, using low light, and then trying to minimize stimulation of the infant. Next slide. Breastfeeding can be an important part of non-pharmacologic care. Breastfeeding has been shown to decrease infant symptoms of NOWS, decrease the need for pharmacologic treatment, and also decrease length of stay. It's important to encourage breastfeeding when the birthing person is in a stable medication-assisted treatment program. If the birthing person is positive for hepatitis B or hepatitis C, they can still breastfeed. However, if the nipples are cracked or bleeding, it's important to consider temporarily abstaining until the nipples are healed. A new Department of Health and Human Services recommendation in 2023 is that a birthing person who is HIV positive on antiretroviral treatment with a low viral load can choose to breastfeed as an option. And providers should counsel and support a birthing person who chooses to breastfeed in these circumstances. Infants who are suffering from withdrawal from NOWS can have a high metabolic rate. Therefore, these infants may have feeding problems or poor weight gain. Supplementing with donor human milk or formula, or increasing the calories of the feeds are ways to help with these feeding issues and inadequate weight gain. Next slide. When thinking of pharmacologic management, it's important to first prioritize a functional assessment. And this can be in place of or in conjunction with a standardized Finnegan assessment that may be in your EMR. You can think about initiating pharmacologic treatment for withdrawal once the infant is not adequately managed by non-pharmacologic means. It's important during pharmacologic management to use continuous pulse oximetry for monitoring. And when initiating pharmacologic management, consider PRN dosing rather than scheduled dosing. If frequent PRN doses are required, then you can consider transitioning to scheduled dosing. Now let's do a poll about medications. What type of medication does your NICU use for infants with NOWS? We'll give you a little bit of time to answer.
About 5 more seconds to answer the poll.
So 84% use morphine, 11% methadone, and 4% I don't know. And that's actually very typical of what we find nationally. All right, next slide. So with regard to medications, morphine is most commonly used for both PRN and scheduled dosing. And a recent study I found said 80%, so very similar to what our results were. Methadone is commonly used for scheduled dosing, and there is some evidence that shows decreased lengths of stay and lengths of treatment when compared to scheduled dosing with morphine. There's limited data on PRN dosing for methadone, but what has come out does show similar outcomes when compared to morphine. For buprenorphine, there's limited research. In the last few years, some studies have come out. They tend to have small sample sizes and aren't always consistent. I think in the next few years, we'll see more information about the use of buprenorphine in treating infants with NOWS. And if adjunctive therapy is needed because the initial therapy is not completely successful, then clonidine is preferred rather than phenobarbital for adjunctive therapy. Next slide. Many hospitals will ask about dosing and what regimen to use. And it's important to note that there's not one specific dosing protocol or regimen that's recommended. We've included in our toolkit several examples from California hospitals, so you can get an idea of the range of protocols that hospitals use. What I'll talk about here are just some general recommendations to consider. So as mentioned before, PRN dosing is recommended to initiate pharmacologic treatment. This minimizes medication exposure compared to scheduled dosing. If you're using morphine, you could consider starting at 0.05 milligrams per kilogram and consider increasing the dose by 0.01 milligrams per kilogram until effective. And this would be for both PRN as well as scheduled dosing. For methadone, scheduled dosing could start at 0.05 to 0.1 milligrams per kilogram, and that would be every 6 hours. A stabilization dose is considered to be reached when an infant is able to meet adequate functional criteria. And as I mentioned before, the toolkit has several different examples of both dosing and weaning protocols. Next slide. So weaning is something that you can initiate after you've reached the stabilization dose, usually for at least 24 hours or so. Studies have shown that gradual weaning using a standardized hospital protocol will decrease the length of treatment. Once the infant is weaned off medication, you could consider discharge if the infant has had no symptoms and is stable off morphine for 24 to 48 hours, or off methadone for a minimum of 48 to 72 hours. And now Kristen will talk a little bit more about the discharge process.
Thanks, Jadine. So when it comes time for an infant with NOWS to be discharged home, there are steps that institutions can take to ensure a successful transition for everyone and their caregivers. So as with our preparation sections, we highlight 4 different areas that units can focus on for successful infant discharge. First, we mentioned ensuring discharge readiness. So what we mean by this is that making sure that caregivers have the support, resources, and knowledge needed to care for their infant at home well before discharge happens. So this can involve setting expectations with caregivers, educating the family about NOWS, ensuring a safe home environment, and following your unit's pharmacotherapy weaning protocols, as Jadine mentioned, when applicable. We also discuss discharge checklists, which help create consistency and improve communication, both with the caregivers, but also among the healthcare team. We discuss connecting with the infant's primary care provider and encourage the use of warm handoffs, again, which many of you may be familiar with, but involves verbal communication between 2 members of the healthcare team. And finally, going back to the institutional preparation that we discussed initially, we want to provide the family with those written resources and lists that you have already put together and are ready to go. This can be a great reference for them since they receive so much information leaving the hospital. They can also just go back and it'll be at an appropriate literacy level for them. It's another important aspect that we mentioned. And then again, just wanted to highlight some of the references we include in this section. We have a discharge, tips on safe discharge, again, another handout from the AAP. We also include a web page from the Agency for Healthcare Research and Quality. This provides guides for families, clinicians, and staff on warm handoffs. We also include a discharge checklist. This is from the Mother and Baby Substance Exposure Toolkit, and it includes a discharge checklist specific to newborns. And many of the recommendations included are also discussed in our toolkit. Finally, we link an example of a plan of safe care template from the Vermont Department for Children and Families.
Thanks, Kristen. So we want to highlight the additional resources that we link to as well. So in this, there are 2 sections. One is comprehensive education. So this will link you to other toolkits that are out there on this topic, educational courses and training websites. So here's one example from the Academy of Perinatal Harm Reduction. So this is a toolkit that they put out. Another one that I think is important to think about is leadership and change management around opioid safety. This is from the California Healthcare Foundation. And then another example is the Mother and Baby Substance Exposure Toolkit. This was a joint collaboration with CPQCC, CMQCC, and Health Management Associates, HMA, that really goes in depth at different best practices across the perinatal spectrum, and is a really great resource for you to reference to if you're interested in learning more about specific topics. In this additional resource section, you'll also find, as both Jadine and Kristen have mentioned, specific California examples from NICUs that have already been working on this in their unit. So these are different policies, protocols, algorithms. Some of them relate to eat, sleep, console. Some of them are general pharmacologic algorithms. So here's one example. This is from Santa Clara Valley Medical Center on their morphine protocol. This is an example from UC San Diego Health on their Eat, Sleep, Console assessment. And then this is from the University of California at Irvine. This is their NOWS management algorithm. And so the goal of providing you these examples is for you to learn from them, to be able to use them as a template to make your own resources for your own unit that are specific to your county's needs, to your patient population, to the level of experience that your staff have, and the census that you normally have of infants with NOWS. So please use those as a really, place to kickstart your own efforts in developing your own algorithms and policies. I will now pass it to Lisa Chi, who is one of our fantastic MADEX co-chairs, to lead us in the Q&A.
Thank you, Caroline. As she mentioned, my name is Lisa Chi. I am a neonatologist at Kaiser and Walnut Creek and am one of the co-chairs of the Maternal Substance Exposure Work Group. We had a number of pre-submitted questions, which we wanted to start with. One, perhaps Caroline or Kristen, you may be able to answer, was how can we work together with our nursing colleagues to provide equitable care for our families?
Great question. So I think a lot of this is discussed in the staff and institutional preparation. In the institutional preparation section, we talk a lot about kind of shaping the culture and having a culture of compassionate care. But a lot of this also goes back to training and educating staff on what NOWS is, addressing stigma and bias. And I think that education and training can help create buy-in. You may also consider having someone in your unit be a NOWS champion, which just means someone who can kind of be maybe the go-to expert, maybe someone who has shown an interest in this area and can really be that go-to person, maybe, a designated person who is given time to look at the latest literature and kind of see what's out there so that they can disseminate that to the unit. Another way that you can kind of get more nurses in particular on board is through collecting data, potentially participating in the MADEX database, just because it can show areas that you could improve, and also maybe show ways that you have already improved to kind of motivate and encourage your team. Yeah.
Thank you, Kristen. And just in adding on to that importance in knowledge that you mentioned, one of the questions that came in on our Q&A was discussing what is the terminology regarding NAS versus NOWS. And maybe that's an important thing for us to clarify. Caroline, did you want to touch on that?
Sure. So NAS, neonatal abstinence syndrome, and NOWS, neonatal opioid withdrawal syndrome, are similar. Previously, I think NAS was used more commonly in AS to include a variety of exposures to different substances. NOWS is more specific to opioids, and is the preferred term that's being used by the CDC and others. Jadine, do you have anything else to say about the terminology there?
No, exactly, that NAS is a more generalized term. I think that when infants are withdrawing from opioids, that's the area where we look at treatment. And so that's why NOWS has specifically become its own entity and is being used quite commonly now.
And I think that withdrawal that's the most common nationally is opioid withdrawal, which is why, as Jadine mentioned, that definition or that word has become more prominent. So another question related to Eat, Sleep, Console is how can we involve parents in the function-based scoring of Eat, Sleep, Console? Jadine, you want to take that one?
Sure. So as I mentioned, we really want to prioritize a caregiver-infant dyad. And the caregiver, we choose to use that terminology because a caregiver can be the birthing person, but can also be anyone that will be caring for the infant, both in the hospital and after discharge. And so rooming in, having the infant be in the same room as the birthing person and the other caregivers will really help with their involvement, because they'll be right there. They'll be right at the infant's side. Studies have shown that these caregivers and family members and birthing people are able to console these infants much more easily than a staff member, than a nurse or a cuddler. Although nurses and cuddlers are also very important with the care bundle as well. So I think really including the families, doing a lot of education, showing them how they're actually quite successful at being able to console the infants, maybe more than anyone else, will empower them and give them the confidence to feel that they can make a difference and really help their infants.
I'll just tag along to that. I think that's a great summary, Jadine. I think some of the resources, the importance of family discharge and education around this are really important, ensuring that you have them available in multiple languages at an appropriate health literacy level for folks. If you have the chance to engage with these families prenatally to sort of give them an idea of expectations of what this might look like for them. One idea that we've seen work really well is this idea of either a parent peer support specialist, that someone is paid by your hospital, or a parent volunteer who has their own personal experience with a substance use disorder. They can be a really wonderful link with families, to have someone who's been there to say, like, me too, I know what this is like. I know how hard this is. Here are some of the resources that I tapped into. That person can be a really wonderful link to create and continue to sustain that trust and transparency that's really needed in caring for these infants.
And there has been a big shift of late, moving more from a physician or nurse-led care of the baby to really shifting to the parents being the champions. So in your center, really messaging that to your hospital staff, that we want to encourage parents to be the number one, the best treatment for their baby. And just tagging on to that, while that is the goal, sometimes parents are not available, or they are unable to. In that situation, one of the questions posed was, what are recommendations of how to take care of a baby when their parents are not available? Any suggestions?
Jadine mentioned a cuddler program, which I think is amazing, and so many hospitals have their cuddler programs coming back online after COVID, which I think is very much needed for many infants in the NICU, but perhaps particularly for this population, when we know that can be a key part of their treatment and training them how to do that. I think another, anyone else wanted to jump in and add on that?
I think one of the parts of that question also was the location of where you can care for these infants. So if, for example, the birthing person is in a different unit or has been discharged, do you monitor these infants in a newborn nursery setting or in a NICU? And I think that's where it's really important to look at what your hospital resources are. If your hospital is able to have a private room situation where some caregiver, maybe another family member, can be with the infant at all times, that's ideal, because those are the quietest rooms. You can control the light, you can control the noise. However, we recognize that some hospitals don't have the resources for multiple private rooms. And so then in that case, the infant may need to be in a group newborn nursery setting, or in a group intermediate nursery or NICU. And if that's the case, then, as Caroline said, you would need to then use the cuddlers, and you wouldn't be able to have the caregiver at the bedside 24/7, although we encourage caregivers to be there as much as possible. So really talking to your hospital administration, trying to be able to provide those resources to give the infant the best environment as a dyad.
Lisa, I remember Lisa helped run a discussion group for Maddox participating hospitals around Eat, Sleep, Console last month. And one of the two ideas proposed in that group as well were baby wearing. These are like, I am sharing ideas. These are not CPQCC endorsed. This is just like in the spirit of sharing things that have worked for other hospitals. Their nurses engaged in baby wearing and the infants who had NOWS. And then some hospitals had also purchased the SNOO, SNOO, which is a self-rocking bassinet that you can set to different speeds and tempos and things like that to help manage those infants when a cuddler or a staff member or family member was not available.
Another suggestion that has been brought up from other facilities who have had experience with NOWS infants is, if possible, as our visiting policies are opening up after this pandemic, that if another family member is identified who can help care for the baby, a grandparent, an aunt, an uncle, we can try to bring them in to help with caregiving if the parent themselves is unable to. Or in many of these cases, sometimes foster care is involved. If that foster parent can be identified sooner, or as soon as they are identified, to encourage that foster parent to begin to come in as well to help with taking care of the baby. So another question, there were a couple regarding toxicology screening. One was thoughts on universal urine or meconium screening of all infants rather than testing through maternal risk factors. Anything you'd like to add on that, JD?
So universal testing in general is really not recommended, whether it's the pregnant person or the newborn. And I think what we're finding is that universal testing can sometimes increase stigma and bias. One person put in the chat, what do you do about cannabis? And is that in your toxicology testing panel? I think as of now, cannabis or THC is in many panels. However, many hospitals, including my own, are actively looking at maybe removing that or somehow having that not be as important when having concerns about the newborn and withdrawal because it's legalized. And so I think that universal testing is something that has been shown to cause more stigma and bias. We're trying to look at more clinically, how is the newborn? And as I said, some hospitals will just go on pregnant person's results to help determine if that would be a diagnosis for the infant. And so less testing has actually been proven to be better, and using Eat, Sleep, Console, it's more functional based. And so if the infant's able to function, then it may not matter what the results of the toxicology testing are.
And regarding exposure, there was a question that was submitted beforehand regarding increases in fentanyl exposure that many centers have seen. And certainly I think that's been a kind of sub-epidemic within the opioid epidemic, especially in the Bay Area, and what can be done in those cases. I think always a good history with the mother and the infant is important. And if fentanyl is identified, often that could be a marker that there may be other illicit drug use, whether other opioids or other substances as well. So in those cases, breastfeeding would not be recommended, in that then the baby may see continued exposure to those substances, making their management more complicated, as well as these other substances themselves can also make withdrawal management more complicated. But always understanding the picture as much as we can is always important to guiding management. And Caroline, there were some questions regarding the use of all the tools that are on our toolkit. Can you talk more about that?
Yeah, so you're welcome and encouraged to use the NOWS toolkit in your hospital, share it with your colleagues. Please do that. And all of the links, all of the additional resources at the end will link you to other sites. So whenever you do use these materials, please give proper attribution to whatever organization or institution created them. The examples from California hospitals at the end, we've received permission to share those with you from those units. So if you use that as a template, please make sure that you just know where it's coming from to make sure those folks receive credit for the great work you've done, but you're welcome to use it widely and freely. Lisa, you're muted, sorry. There you go.
Going back, I muted and unmuted and muted myself. Going back to the drug testing, I think Jadine, you touched upon the different options available. There was a question about the pros and cons of cord tissue sampling. I know you had some info about the timing of how quickly it would come back, but anything else to add to that?
So testing for meconium and umbilical cord, as I mentioned, goes back farther, usually into the 3rd trimester of pregnancy, but it does take longer to get those results compared to urine. Hospitals that have implemented the umbilical cord testing over meconium have said that first of all, it's much easier to collect because you collect that at delivery, but you do have to get your hospital on board and your laboratory on board to make sure that that collection can happen and can be in a timely manner sent to the laboratory. There's also an issue with storing the cords. In some cases, you would need to allow for storage of the cords if it's not going to be sent right at delivery. And then most important would be the cost. And in talking to hospitals who have implemented the umbilical cord testing, those hospitals have found that switching to umbilical cord from meconium is cost effective, maybe equal or even less costly. But I've also spoken with hospitals who say that umbilical cord testing is quite a bit more expensive. So that's where you need to speak with your individual laboratory to find out some of these details.
Thank you for that clarification, Jadine. And there was also a question about SSRI withdrawal, and Jadine had mentioned that many of these families do have co-exposure, so that's a very important question that you bring up. And SSRI usually presents much sooner, so it is important, for example, if you have a mom that was on methadone where you would not expect withdrawal to appear until maybe day 3 to 5, if a baby in the first hours of life is tachypnic and jittery, and mom was on an antidepressant, that perhaps that is SSRI. So the first thing is education with staffing regarding timing of symptoms that can sometimes point towards what the cause might be. In terms of management itself, usually this is related to the surge of serotonin that the baby will have, and it's usually self-limited. And the most important thing is supportive care of the baby during that time for whatever symptoms they may have. And then there was questions regarding the adjunct medications. I know you talked about morphine and methadone as the primary. Jadine, do you want to touch a little bit more about clonidine or phenobarbital or other medications that people have used and the pros and cons?
Sure. So if methadone or morphine are not sufficient to be able to control the infant's symptoms, then an adjunctive medication can be considered. And I think phenobarb was used quite frequently in the past. But the problem with phenobarb is it doesn't really help the GI symptoms that we see these infants have. And because of the CNS depression effects of phenobarbital, there's impaired bonding, impaired feeding, and that kind of goes against what we're trying to do with our functional scoring. And there also could be potential long-term neurodevelopmental effects with phenobarbital. So more hospitals are using clonidine now as their adjunctive medication. And the clonidine will inhibit the CNS sympathetic outflow. It'll decrease the norepinephrine levels and therefore decrease the autonomic symptoms of NOWS. And so more and more hospitals are going to clonidine as adjunctive treatment. It's important to keep infants monitored during the time on clonidine. And then with regard to weaning, as I understand it, you want to do two-step weaning and not all at once to avoid recurrence of withdrawal symptoms. In the toolkit, we've listed some references that you could go to find out more information about clonidine.
I see a question in the Q&A regarding a difference in the threshold, I think, to treat between those on Well Baby Nursery and those in the NICU. I know you talked a little bit about preparation of the hospital and staff for this. Kristen, did you have anything to add?
Yeah, I think this kind of goes back to, and I don't have big recommendations on what that threshold is out of the VJ team, but I think it's important to reach consensus. And so I think that is where definitely training your staff on what the latest evidence shows, because, you know, as we have seen, it's constantly changing, you know, what the research is showing, or we're constantly getting more and more research on this area. So I think just staying up to date with the research, but also, you know, getting those teams together so that they're not in silos, so that they can discuss, you know, if they're going to have different thresholds, why, and what those different parameters might be. I don't know if anyone else has anything to add to that.
I think that's a great point you bring up, that a lot of this is bringing all the key stakeholders together beforehand, so everyone has the same goal and is on the same page, and hopefully try to avoid some of these conflicts in what threshold you would have to treat. There was another question regarding duration of monitoring, because many of these babies will need to be monitored beyond when mom would still be there as a patient herself. And I think the main question is, where would you follow these babies? And it depends on where the baby is at. I think if the baby's having significant withdrawal, needing medication, then that baby would likely be in a NICU. For those on the call, some might be in a pediatric unit. If the baby's still being observed, but not needing pharmacologic treatment, if your hospital allows it, many facilities have found success in keeping these babies on the mother baby unit. The baby would be a patient, the mom may not be, and then rooming it could continue. There is precedent for that in many facilities, in that, for example, babies who end up needing phototherapy in many centers can remain on the mother baby unit with their family. So that might be the precedent for your unit to do that. Similarly, for a baby who's just being observed for withdrawal but not needing medication. I don't know if any of you have anything to add to that from your feedback from other centers. Yeah. Okay. Well, regarding all of the other questions, we will try to answer as many of we can, either in the chat or in a follow-up email with you. I think Caroline had a couple of closing remarks for us.
Thanks so much, Lisa. These are really great questions. I would encourage you, if you're interested in discussing this at the more micro level for your unit, please join one of our featured discussion groups within MADX. Here again is the QR code to take you to the toolkit. And Kristen's also going to drop a link in the chat to do a very brief 1 to 2 minute evaluation, which will help us better understand what you'd like to know about in future webinars, or as part of future toolkits, and help us improve the content that we deliver. Because if it's not useful to you, then that's really our main goal, is making this something that you can use and take and run with in your unit to improve care for infants. So thank you very much for joining. It's been a joy to develop this toolkit, and an even bigger joy to get it delivered to you today. So thank you very much, and enjoy the rest of your week.